introduction, my name is Dr. Jamie Marich. I have a trauma-focused private practice down in the Youngstown-Warren area, which is where I'm originally from. I do travel the country and now the world talking on really so many topics connected to trauma, whether it's the trauma-addiction interaction or differing treatment modalities for trauma, such as EMDR therapy, mindfulness, and expressive arts therapy. So it's my great pleasure to be here home in Northeast Ohio today on an afternoon that's just a fabulous bill. I get to be in between two of my favorite people, Dr. Chris and Karen. So Chris said something very interesting in her talk when she went into the material about the biological basis for the disease of addiction. She used an interesting phrase, the broken brain. And I've been around this field long enough to know that we get into various areas of debate about, well, what exactly is breaking the brain? What exactly is causing this tendency towards addiction in the brain? And we can get into these discussions. Is it nature? Is it nurture? Is it both? And I've never really liked that idea of nature versus nurture, but rather there are certain biological predispositions and there are things that happen to us that could make our brain very vulnerable to developing the disease of addiction or exacerbating it. And I'll give you a little bit more on that idea of exacerbating it later. I'm here to propose to you over the next hour that trauma, unhealed trauma, untreated trauma, can be one of those factors in what disrupts the normal functioning of the brain that can make addiction very, very appealing. Dr. Chris also talked about some of the models for addiction, and after we get on the same page here about what trauma is or isn't, I'll give you some insight onto how a lot of trauma-focused providers look into describing addiction, and of course something we're here to talk about today, which is what are the solutions for treating addiction. All right, so it's not that little known at this point. I actually started out in this field as an English teacher. Well, I shouldn't say I started out in this field, I started out in this life as an English teacher. I'm an English teacher, performing artist by background, and if you told me when I was a 19-year-old undergraduate that I would ended up as a counselor, I would have laughed in your face. I had absolutely no intention whatsoever to be doing this work. And I ended up serving in Bosnia-Herzegovina from 2000 to 2003. So for those of you needing the refresher on current events, there was a horrible civil war in the former Yugoslavia during that period. And I was there offering services as a provider, teaching English and music primarily. And it was there that I was introduced to my first mentor, who, after I got into my own recovery program, she sent me back to the US kicking and screaming, saying, go to graduate school in counseling, you'll like it. And I laughed in her face, and here I am 15 or so years later. So let's talk about trauma. And I am way more of an English teacher still than I am a scientist when it comes to talking about a lot of these clinical terms, such as trauma. Dr. Chris gave us a couple great infographics and pictures about the human brain, and I'll be referencing those in a minute. But I want to break apart what the word trauma means, because I think that really is at the heart of understanding and clarifying a lot of the misconceptions we have about trauma and what it does to the brain. So I'll invite you to get out a scrap piece of paper. I know you all have materials there, something you could write with very easily. And I will give you about a minute or two. Please don't overthink it. You're not being tested, you're not being graded. To write down, to jot down what your working definition of trauma is coming into this workshop. All right, if you're still writing, if you're still jotting down, that's quite all right. But I do find as we go into this next section here, just exploring and unpacking the word trauma, it's helpful to know where you're coming from. And as you hear some of these others' ideas and definitions explored, you may be surprised, or you may see that maybe my thinking, my reasoning kind of has been where a lot of the thinking of the field is going about unhealed trauma and how it affects human behavior. So can I get a couple of you to share what you came up with? You're not getting graded. You'll not be publicly shamed or scorned if I don't like your answer. But I'd like to hear, a room this size, maybe from about 4 or 5 of you, what you have come up with defining trauma. Now you will have to go on the microphone because we're in a big room. I'm going to get my workout like a talk show host coming around, but that's what I like.
I just kind of went with whatever was on the top of my head. So, motive, physical, or psychological reaction to an acute or chronic negative life event that is directly experienced or perceived.
Thank you. Directly experienced or perceived. Perceived is a big part of the definition. Anyone else, as I walk through and you're compelled to share, grab me. Right here?
Is never-ending hell on wheels in your brain.
I love that. Never-ending hell on wheels with your brain. I like to keep these things pretty simple. You'll see my definition here in a minute. I like that never-ending hell on wheels in your brain, specifically your limbic brain.
Mine's real simple. It's just an event that changes your life.
Yeah, an event that changes your life. Let me come back. I'll go back here via here.
A life-changing, life-altering, negative life event before which you are one person and after which you are someone completely different, never to return to the person you once were, even with all the effort in the world.
Thank you. Thank you.
Well, since I am recovered from trauma, I'm going to give my definition. The inability to understand why you make decisions based upon life changes because you do not have the ability to process what just happened to you. And at 45, I figured it out.
Thank you. Very well put. All right, I'm coming back through here.
Physical or emotional experience that lasts and causes lingering injury emotionally and physically.
Thank you. Lingering, lingering, lingering. And anyone else, as I make my way back up to the front of the room, if you want to grab me in the microphone, love to hear from you. I really like what has been shared and contributed already. Hold on to your definitions. Hold on to what you wrote down because it's probably not wrong. And what I mean by that is trauma really is a subjective experience. I heard one of the individuals use the word perceived in their definition. What may be traumatic to me may not be traumatic to you. And that's a big source of the debate and controversy when we talk about trauma, especially in traditional addiction communities. I hear things even from clinicians like, it's time to get over it. It's time to prey on that resentment. The reality is what's traumatic to me may not be traumatic to you, and vice versa. How it has processed or failed to process in my brain may be completely different than how it has processed or failed to process in your brain. So it is very subjective. One of the things I want to try to get us out of is a bit of this bias that still exists, especially in traditional addiction circles, that trauma is PTSD, that trauma is just the post-traumatic stress disorder diagnosis. I think most everybody in this room has heard of post-traumatic stress disorder, which is a diagnosis that first debuted in the DSM-3 in 1980, largely as a result of political maneuvering following Vietnam. But PTSD is not unique to the Vietnam War. It was not invented with the Vietnam War. In previous military conflicts, other names were used like operational exhaustion, shell shock, battle fatigue. If you want a great commentary on that, look up George Carlin's euphemisms. It's one of his most famous stand-ups. And he talks about how our field has done a fabulous job of jargoning the pain. And I tend to agree with his perspective, only the shadow side of that is I am a clinician and a teacher who has to teach other clinicians who have to do things like diagnose so that you can bill and get treatment paid for. So if you do want to look up the post-traumatic stress disorder diagnosis, I think they've made some positive strides in improving upon it here in DSM-5. But too often, especially as I came up into the addiction treatment world, I heard things like, well, it's not PTSD, so why do we have to even worry about trauma? Or they have to get their addiction stabilized first before we can even touch the PTSD or the trauma. I was very happy to hear Dr. Chris do her section on myths, and that is a myth that I have worked my whole career here to combat. That you could be trauma-focused, you could be trauma-informed, without even directly going there to looking at the event or the experience itself. And hopefully I'll give you a case for that position to addiction treatment as we move along. But before I do that, I need to share with you my working definition of trauma. So, does anybody know where we get the English word trauma? Here's my English teacher coming out here. What does the word trauma even mean? Because by unpacking this and exploring this, we will really get a lot of fabulous insight here into how we can approach this clinically, socially, behaviorally. What does trauma mean? Use this to help you. Injury is close. Damage from an outside source is close. Has anybody ever seen that movie, My Big Fat Greek Wedding? You know how the father would say, give me a word, any word. And I tell you how it comes back to Greek. It's Greek. And he's exactly right with this word. Trauma comes from the Greek word meaning wound. Wound, W-O-U-N-D. It is a simple, direct translation. Trauma means wound. So when Dr. Chris talked about the broken brain, when we're talking about the brain affected by unhealed trauma, we're talking about a wounded brain, specifically wounding to the limbic brain, which was that middle part of the brain she showed on her diagrams. That middle part of the brain where dopamine is released, where the nucleus accumbens is. That's also the part of our brain that gets activated when we're in these situations of high danger, high alert, threat to safety, lack of nurturing. And just like that limbic brain kind of turns on and juices up to keep us safe, part of what unhealed trauma does is we never move past that sensation that we're not safe. And the limbic brain works harder and faster than it's intended to. But I'm getting ahead of myself. Stay with this idea of trauma as a wound. Let's put aside emotional, verbal, spiritual wounding for a moment. What do we know about physical wounds and how they heal? If your answer's short, just kind of raise your hand and call it out. I'll repeat it on the mic. What do we know about physical wounds and how they heal? Yes? They leave a scar. Now, do scars hurt? I get a lot of, what's the right answer? They can. Yeah. Some scars hurt, some scars don't hurt anymore, some scars, it depends. Like on a rainy day, you may feel a little irritation or agitation. A lot of what determines those variables of if scars hurt or not is, was proper treatment received at the time? Did infection set in at the time of the injury? And a lot of why infection sets in is why? Because proper treatment wasn't received. Where was the scar? How deep was it? Was it a clean cut or not? You know how Dr. Chris said there's no one size fits all? I would argue the same thing applies to both physical and emotional trauma. What else do we know about scar or wounds and how they heal? Yes, for proper healing to happen, it really must be from the inside out. Yes, most wounds will require some type of stabilizing care from the outside in. We may have to wash it out, stitch it up, put a bandage on it. But true healing has to be from the inside out. And one of my biggest criticisms of the traditional addiction field, which I have a lot of respect for, So I'm a woman in long-term recovery and largely got there through some traditional means. Is it's perpetual stabilization, it's perpetual bandaging, it's treating things only at a cognitive verbal level. And if we have some spiritual work, that can help, but we're still not getting to a source of what makes a lot of people hurt. And that's where the deeper work is required. And we know that with physical injury, right? We have to treat the source. What else? Physical wounds and how they heal. Yes?
More often than not, the healing is linear.
Maybe, depends on the injury. More often than not, the healing is linear, that there can be a prescribed course, like Dr. Chris said, a predictable set of signs and symptoms that a disease may follow, and there could be a predictable course of how treatment will go. But especially with complex trauma, life, other variables may throw you some curveballs here, which can make the healing process a bit erratic. But with proper treatment and support, it can be managed. Anything else about physical wounds and how they heal? Yes?
Well, it's not physical wounds, but the healing process seems like
you went through a traumatic situation, that it's understanding how, perhaps help looking back and understanding how it affected that 8-year-old and how it affected that person that went through that traumatic.
getting some understanding.
Sure. I warn you, I could talk about this metaphor for a whole day course, so I am going to wrap this up here pretty soon. There's a few more big comparative points I want to hit on. If you go to my website, Trauma Made Simple, which I'll reference at the end, I did a TEDx talk 2 years ago on this whole trauma as wound metaphor that you may find some of your clients will benefit from as well. But I want to cover 3 main things. Let's say that this is a soccer player who gets his knee injured or scraped up in a game. What could happen if he goes back in the game and doesn't treat that wound or treat that injury? What could happen? Yeah, that's usually the result once I get further injury. Another player could take advantage of the fact that he's hurt and try to take him out. It could get hurt worse. It could fester. It could infect. He could put others at risk. Because let's face it, even the medical model has grown savvy to the fact that open blood sores are not considered safe. And I know many of you have heard that aphorism before, hurt people hurt people. We talk about that with addiction all the time, but the same thing applies with trauma. That unhealed trauma is like running around in life with a gaping open blood sore. Others can come into contact with that and be put at risk. And in the physical healthcare professions, we have gotten more savvy about things like universal best precautions to not, hi Marich, to not transmit bloodborne pathogens. Yet so many people are running around in what I feel is a national public health crisis of unhealed trauma affecting each other with our untreated injuries. But here's the other scenario. This soccer player could go back into the game and nothing could happen. He could be expected to go back into the game and just deal with it. He could go back into the game and score the winning goal. And then what will happen? What will he be called? A hero. He's resilient. He rose above, conquered. But what if he would have needed to stop and ask for help and say, I need to get this treated? What would we have said? He's weak. Maybe even ascribe some choice names to this need to ask for help. And I bring up this part of the metaphor because that's what we do with wounding. You don't have to call it PTSD, but with small t trauma, this idea of trauma as wound. We praise the people who can rise above. That's not to say that's a wrong thing, to be able to be resilient and maybe even not that bad to push through, although if you're pushing through without really treating the injury, you may be causing yourself further damage later. Here's why I'm not giving you statistics. in this presentation today. First of all, I kind of don't like PowerPoints anymore, but they're almost expected at conferences. I'd rather us just have a conversation for an hour. But here's why I think most statistics in this kind of trauma and addiction overlay are not that credible. Because if you read a lot of what are out there about the comorbidity, at least between PTSD and substance use disorders, you'll see numbers like, it's very high in women, but it's not as big of an issue in men. Trauma, PTSD. As a clinical provider, I think that's hogwash. My experience is that trauma affects just as many male clients as it does female clients, but we're not often able to hear about male clients' experiences. Why? Because you gentlemen are socialized not to want to admit it or talk about it. Or there's an even worse stigma I have experienced around a male disclosing sexual abuse than a male disclosing alcoholism. Trauma affects all of us. Trauma affects all of us. Another angle on this, going away from the gender for a moment. What are the 3 unwritten rules of an alcoholic home? Don't talk, don't trust, don't feel. All 3 of those rules are antithetical to trauma being healed or processed, to the wound not getting fully treated. And then we continue to run around contaminating each other with our wounds. And then the other part of this metaphor I want to draw out is that some wounds may never truly heal. I know that's hard to say, and I may sound like a pessimist, like, but Dr. Jamie, aren't you a trauma specialist? Don't you believe people can recover? Of course I do. But let me give you this example. My friend Heather was born with one leg. It was due to her father's Agent Orange exposure during Vietnam. Heather will never get her leg back. So in a pure, go back to the way it should be, Heather's leg will never heal. But what Heather has been able to do is adapt. And at least in the school of trauma therapy I work in, we use that word a lot, adapt, adaptation. Using materials like a good prosthetic, having a spiritual support system, a social support system, a good sense of humor, artistic coping skills. Heather's now a licensed professional, owns a business, and I think anybody would agree she's more functional than a lot of people with 2 legs. So healing could look different for different people. I like whoever said it's not going to go back to the way it was. It probably won't. I had another client very recently who told me, I feel like this trauma, because she had a lot of complex sexual trauma over time, shattered me into 1,000,000 pieces. And how do you ever put all of that back together? And my blunt answer to her was, I don't think you ever do. But you can take those 1,000,000 shattered pieces and turn it into something like a mosaic or a work of art. And she came back to her session the next week, I wish I did have a picture of it, literally with a glass mosaic that she made for me. And I just think that's a perfect metaphor here for what trauma healing can look like. So I know one of the concerns, I'm sorry, my sarcasm's coming out there, from a lot of circles in traditional recovery is, but if we talk so much about trauma, we're just giving people excuses. Because one of the old school resistances I've heard to this whole idea of trauma-focused care was, well, Carl Jung and all these people who existed before Bill and Bob, they tried to treat the source of what was plaguing a person and found that it didn't quite work, that a person needed a spiritual change, a person needed a psychic change. So by talking about trauma, we're just giving people excuses. Although I want to validate that point and that perspective, and I have had to work with clients who do want to make their care all about their trauma and not anything else, my experience is it's usually the opposite side of that coin. That people are more likely to minimize their traumatic experiences. Do you all know the scene from Monty Python? It's just a flesh wound. The Black Knight loses his arm in battle. He's bleeding out. He's bleeding out. And he keeps fighting because he goes, it's no big deal. And a lot of abusers will use that, by the way, as a tactic. Like, you don't know how good you have it. There are kids starving on the other side of the world. And here you are complaining about how bad you have it at home. And then the Black Knight goes ahead and loses another arm, and he's bleeding out, and he's bleeding out. Oh, no bother, it's just a flesh wound. Then he loses his right leg and his left leg, and he's still fighting. That is most of my clients that I've ever treated. That is most of my clients I've ever treated. So some of you may not like me for this, may see it as bordering on the political, but this is a sentiment I have seen connected to trauma, connected to the opiate crisis, that people are just a bunch of oversensitive ninnies, pansies who just need to get over it. If you can't see it, it says politically correct, a term used for whiny, oversensitive pansies who need everything sugar-coated. This invalidation is a lot of what keeps the legacy of trauma alive in that limbic brain, that middle part of the brain diagrams, that keeps us thinking like things are still happening over and over and over again. And here's the thing I've come to learn in studying trauma, treating trauma, about that limbic brain, that center part of the brain that Chris showed us on her diagrams. The limbic brain literally has no clock, or it's not the same kind of clock or same kind of time scale that that prefrontal cortex has. So when our brains are still stuck in that panic button, and sometimes it doesn't get stuck and jammed all together, it could be at various degrees of activation, but we lose a sense of the time scale. So one of the worst things we can tell survivors of trauma, and remember, not just PTSD, any kind of wounding, physical, emotional, mental injury that may show up in some other diagnoses, if there's limbic brain activation, your brain may still process it or fail to process it as if it's happening today. So please don't ever tell somebody, that happened 50 years ago, why don't you just get over it? Because if they've not processed it, if they've not healed it, 50 years ago feels like today at the level of the brain. As I'll talk about here before my talk is over, I am not anti-12-step. I recovered, and we're recovering through a 12-step fellowship. But I do think we can use the principles of the 12 steps abusively in some of our treatment centers and with some of our clients. And although I think there's a lot of inherent wisdom to a slogan like one day at a time or just stay in today, if we throw that slogan at a trauma survivor and expect them to just take it as truth and run with it, it may be nearly impossible for their brain to do that. Because if they're still stuck in that trauma loop without it being healed or addressed, you're still living in that timeline in one degree or another from the original trauma. So a lot of the work that I have tried to do, one other point of clarification before I go on, and if I had longer with you or if you ever came to one of my whole day courses or read one of my books, another thing I emphasize is that what we're learning about trauma now, especially in the last 20, 30 years, which has been a big burgeoning, really a flowering of information and research about how trauma affects the brain and how trauma affects behavior. That trauma shows up in way more than just the post-traumatic stress disorder diagnosis. And even the DSM-5, for all its faults, has taken some steps in the right direction to acknowledge that. Trauma now gets its own chapter. Trauma and stressor-related disorders. Post-traumatic stress disorders there, acute stress disorders are there, adjustment disorders are there. That's probably my most favorite change in the DSM-5, because it validates that these stressors, these things that happen in life that are wounding, but we're not going to make the national news, can still cause the brain to be in that state of activation that, if left untreated, will continue to cause us problems. Reactive attachment disorder, which if you work with kids, is an important diagnosis to know about. That's where we see things like abuse and neglect in early childhood really manifest as lifelong problems with attachment, with behavioral conduct, with being able to form healthier relationships later in life. And then even with substance use disorders, eating disorders, I'm not going to get into the whole debate here about the chicken and the eggs, which causes which. Just know that trauma is a part of anybody's story who comes to you with a substance use disorder diagnosis. And what I mean by that is even if a person is a pure genetic predisposition case, nothing bad really happened to them in early childhood and their brain was just wired for this, anybody who is out there is likely going to get traumatized or wounded in the pursuit of satisfying the addiction. And I've seen so many people shamed for that, especially people who are opiate addicts, feeling like, well, I brought this upon myself. So the fact that I was shot when I was going out to score doesn't count as a trauma. It definitely does. So even if trauma is not part of the cause, it can be part of the exacerbating factor of what keeps that limbic brain so stuck. What keeps that limbic brain so stuck? So what do we do about it? I want to spend a good part of the talk here talking about what to do about it. Now, this slide is pretty old. I'm going to admit that. It was a model that was first introduced in 1995 about how to tie it all together. Yet to be quite honest, I have found few that I like as well since this. And so much of the literature that has come out in the last 20, 25 years since this Evans and Sullivan book was published has really gone on to validate this model. And why I share this model with you is it's a beautiful model for those of you already working in what I generally have been calling traditional addiction treatment. Treatment centers that can be pretty 12-step focused. Pejoratively, I would say treatment centers that could be pretty set in their ways. About this is how we do it. I'm a big believer that's the most dangerous phrase in our lexicon, but this is the way we've always done it. And we have to be able to look at some new ideas, new avenues, new solutions. So this is a 5-point model, and as I go through it and just give some commentary on each cog, just maybe note, is this something I believe? Is this something I'm putting into action, either as a clinical treatment provider or someone out in the community? First of all, a large portion of clients presenting for treatment in any setting, inpatient, outpatient, medication-assisted treatment, have a history of trauma. Respecting this history enhances treatment. Respecting this history enhances treatment. That is the essence of what I mean by validating. This happened to you. I'm not going to try to argue it. I'm not going to try to change it. I'm not going to tell you things like, you're too early in treatment to be talking about your trauma. No, don't do that yet. That's invalidating versus, hey, I don't know what flow in your treatment is going to be the best time to go into all these parts of it, but I want you to hear that I hear your story. I hear this happen to you. That can be a powerful intervention in and of itself, instead of, don't go there. Anybody in here ever hear of Stephanie Covington, one of the great leaders in the more progressive 12-step based field? She wrote A Woman's Way Through the 12 Steps, was really, I would argue, one of the founders of gender-specific treatment for women. And she tells this great story when she keynotes that in 1982, so that was before trauma was even a cool word in addiction treatment circles, she gave a keynote presentation on the legacy of sex and violence in women's recovery. And she said, after the presentation, all of my colleagues just about stoned me. How dare you talk about that at an addiction conference? Our clients aren't ready to deal with that. And she said, as I heard everybody's protests, what I was hearing in that is, we're not ready to deal with it. And I believe that totally. So if you find yourself getting squishy, squeamish when people want to bring up trauma, I'm not saying you're a bad person. Please hear that. But it may mean there's something inside you may have to look at, or some work you may need to do, training you may need to have a little further to be okay with people going there about trauma. Oops, I think I'm on timer. That's why it's going through. Number 2, successful treatment of the trauma must include working through memories of the trauma in an experiential way. So part of what that means by an experiential way, it is not enough just to talk about it. I'm going to say that again. It is not enough just to talk about the trauma. How many of you have run or worked with clients who can tell you their story verbatim, but they're still stuck at this heart level? How many of you have clients who know recovery so well you would trust them to run your group, but have still not gotten sober or well long term? A lot of that is the treatment hasn't gone deep enough. It's not gone into the emotional level, into the heart level. And this is why so much of the trauma-focused field now is moving towards interventions like expressive arts therapy, EMDR therapy, which is the eye movement therapy, somatic experiencing therapy, which is really encouraging people to move their bodies, to go there with these parts of our experiences that we can't easily get to by just talking. The other thing from Dr. Chris's diagram, the prefrontal cortex, that's where language happens. And that's important. It could be an important part of the treatment process, but that's not fundamentally where the injury is. So teaching people things like how to breathe and how to move and how to sense into their body and listen to cues in their body and express something with a story or a song may be more effective than giving me one more recitation with words of your story. And even people who do things like write and do poetry, there's still more of an emotional conjunction behind that, which can make the words much more powerful. So this is the big concern, the big criticism I get from traditional addiction providers, but I don't want to make them worse. What if going there about the trauma makes them worse? So something that's always been written into these trauma-focused models for addiction treatment is after the clinician and client have established a foundation of safety and coping skills. So you can be doing trauma-informed, trauma-focused treatment without them telling you a single thing about what happened to them. If you are, especially in IOP groups, teaching tangible, usable skills that people can do when they feel triggered, when they notice a craving coming on. And I'm not talking skills like think the drink through. That's prefrontal. I'm talking skills like take a walk. Even call your sponsor. Although that's a verbal action, you're still picking up a phone. You're getting into action. I love the adult coloring books that are out now. That always sounds so dirty, adult coloring books. But seriously, you can use a regular coloring book. It's very action-based. Programs like Seeking Safety, the DBT skills, mindfulness-based skills, have a lot of fabulous curriculum ideas for getting people into action. My first sponsor was this boisterous, beautiful woman from Kentucky who would say, Chapter 6 of Our Book is called Into Action, not Into Thinking. And I think action can dictate a lot of our coping skills, not let's just sit around and talk about it. So this is one of those, I don't care which came first, the chicken or the egg. I know there's a chicken and an egg. So let's treat both, regardless of getting into these debates about which caused which. So substance use disorders are a significant part of the clinical picture for a substantial number of survivors of childhood abuse. Thus, treatment of the abuse issues that does not address the substance use issues will be ineffective. Because I want to make a point of this. I've taken a lot of criticism from many of my colleagues in more of the trauma mental health circles. When I go to EMDR conferences and trauma conferences, they'll tell me things like, why do you still believe in those 12 steps? They're old, they're antiquated. We just have to treat the trauma and the addiction will clear up on its own. And I'm like, that's a very naive perspective because you're negating a lot of the damage the addiction has already caused to the brain. And even if you're equipped with all the latest technologies in treating trauma, like EMDR, somatic experiencing, you need something that will help bring about healthy lifestyle change too. And I have always found the 12-step model delivered in a healthy way, because so much of my soapbox is there's a lot of treatment centers and meetings that do horrible things, like tell people who are dually addicted, you can't talk about this drug here, or you can't be here. I'm going to breathe and move on, because that makes me very upset. And then treating only the addiction in those with survivor issues will likely be ineffective. This whole, just treat the addiction, except you have a disease. And then when you do your 4th and 5th step, the trauma will clear up. That's naive too. So, something that Evans and Sullivan have said is that 12-step recovery, conventional addiction treatment, is still useful. There's no need to throw the baby out with the proverbial bathwater. But when we're dealing with survivors of trauma, and now we have such a greater understanding of how pervasive trauma is, it's not enough. So the final point of this is treatment models for addicted survivors of trauma must be integrated and must address the synergism of trauma and addiction. A 2-track approach is likely ineffective. And I see what often happens is the mental health counselor's over here, the addiction counselor, the IOP's over here, and never the two shall meet. That's not good. Even if as a provider or as an agency you're not set up to offer both, are you engaging in collateral care? Are you engaging in collateral care? So some of you are familiar with my book, Trauma in the 12 Steps. I wanted to kind of start to wrap up this talk by giving you a little bit about how this book and how this project came to be. So probably 2009 is when I started doing more widespread education on trauma out there in the community, really trying to expand these conversations about what trauma is and what trauma means. And I had a lot of addiction colleagues come up to me and say things like, you better be careful, because people are going to get worse if you go there too soon about the trauma. And my response is, people are already getting worse by us doing nothing. And yes, I'm not advocating that we pull people off the streets who are actively using heroin and engaging in deep retrogressive hypnoses right away. There's a responsible way to do it, but we have to be doing it. We have to be addressing this notion that trauma affects people. And I also got a lot of criticism, I already mentioned this, from my mental health colleagues who thought I wasn't being aggressive enough in talking about trauma, that 12-step and traditional work is antiquated. My answer has always been we need both. Needless to say, I didn't last very long working in a lot of the traditional 12-step only type facilities. I was usually the one who people rolled their eyes at me saying, oh, there's Jamie talking about trauma again. But part of why I would talk about trauma is 2 reasons. One, I got into this field through a trauma-informed lens before that phrase trauma-informed was even cool. Because I had a sponsor/mentor who was working with me in Bosnia, who helped me to understand that the reason kids who were just a few years, not only post-war, but post-communism, had a hard time staying focused in school, had a hard time doing math, had a hard time paying attention is because unhealed trauma was wreaking havoc on their brains. And another thing I learned in Bosnia was just how healing the relationship really is. And that's one of the reasons I will never be anti-12-step. As much as I've been trained in all these other fancy modalities, that when 12-step is done well, when it's done in a healthy manner, there is still something so powerful about one addict helping another, or one treatment provider helping another individual. And even what the work of Dan Siegel has shown us now, interpersonal neurobiology, is that the healing quality of that relationship, all the Carl Rogers stuff we used to laugh at as being too fluffy, really does bring about change at the limbic brain, without us maybe even having to say a word, but simply validating, I hear you, and I'm here. So trauma in the 12 steps resulted because I got feedback from various corners about, oh, you seem like this normal middle ground. You're an addiction provider who is not so anti-trauma, and you're a trauma provider who's not anti-12 steps. And so I wrote this book really as a response to some of that. Because I do have problems. I have legit problems with a lot of things that go on in meetings, with a lot of things that go on in treatment centers that I think go against what we've learned about trauma. Because the reality is we've learned a lot since 1935. So in the book, I take on some of our age-old slogans, like take the cotton out of your ears and put it into your mouth. and how that really is promoting more trauma getting stuck in the limbic brain, and how we really need to watch our language. And that may mean stepping aside from some of that, well, this is the way we've always done it. And if a pretty raw trauma survivor can't quite deal with the phrase like character defects, are we willing to help them develop a phrase that they can work with and that they can stick with? Instead of saying, this is the way we've always done it, this is the way that Bill wrote it in the book. And I also talk about some of my concern with treatment centers who have the this is the way we've always done it mentality, who say things like you can't even touch the trauma until you accept you have a disease and work on your addiction. Remember what I said as we discussed the Evans and Sullivan model. You may not be doing the deep work right away, but you can be doing trauma-informed care from day one by introducing action-based, body-based coping skills that understand how the brain works and how unhealed trauma affects the brain, and by validating people, by showing some of the basics of compassion. So I would like to send you to one of my websites, which I think is more powerful than any PowerPoint I can give you. And this is TraumaMadeSimple.com is the easiest way to access this website. It's the website that I have set up for two of my book projects, Trauma Made Simple and Trauma the 12 Steps. And this is a great one-stop shopping resource we've designed to be client-friendly. Anything free I have done online is on this website. So I have a lot of videos on YouTube right now, EMDR demonstrations, mindful living coping skills. We're expanding that library now as my new book is getting ready to release. Any blogs that I've done, you can get on this website. So for clients who have YouTube access or internet access, but they're not the type to really buy a book, please send them to this website, and you're free to use it yourself as well. You can screen out some of these skills, because when I talk about things like we have to get into action-based skills in our IOPs and not just sit around and talk about stuff, you can get some good insight into what some of these skills are, especially under the videos tab. So I want to thank the committee for inviting me to speak. Over this break, I will be out at my table. My group here is Mindful Ohio and the Institute for Creative Mindfulness. Mindful Ohio is my private practice down in Warren. Institute for Creative Mindfulness is our training wing. We do EMDR trainings. Hopefully we'll be doing one here in Portage County next year, but I do offer them pretty regularly in Cortland and Cleveland. So if your interest has been piqued about EMDR at various parts of your training, please come and see me about that. I also do some fun stuff like dancing mindfulness and expressive arts therapy, which again, to me, it's what has helped the most in a lot of my healing journey, and I'd be happy to come and visit with you. I also have little 3x3 cards for this website, Trauma Made Simple. Please come and take them all. I don't want to take any home with me, and you could have them at the ready to send to clients. So happy Halloween. I hope you get a treat or a trick at some point today. You're in for a treat with Karen here at 4. And thank you, Dr. Marich.
Thank you, Judy.